Hello, good afternoon. I hope you all had a great lunch. My name is Katie Lee. I'm the Director of Communications at Mental Health America, and I would like to welcome you to the third session, Digital Innovation, the Role of Google and YouTube in Connecting and Engaging Mental Health Patients on Online Platforms. With us today is Dr. Megan Jones-Bell, Clinical Director of Consumer and Mental Health at Google. She was formerly Chief Strategy and Science Officer at Headspace and helped guide Headspace through its transformation from a meditation app into a comprehensive digital mental health platform, Headspace Health. Dr. Jones-Bell founded one of the first digital mental health startups, Lantern, where she pioneered blended mental health interventions leveraging software and coaching. She also serves on the board of the Child Mind Institute and Castaneda School. She is a fellow of the Aspen Institute Health Innovators Fellowship and a member of the Aspen Global Leadership Network. Let me turn it over to Dr. Megan Jones-Bell.
All right, thank you, Katie. And what an act to follow. This morning was so stimulating and inspiring. After lunch, will do my best to follow their lead and keep the energy up. So I have the great pleasure of sharing the work that Google is doing in health. And I thought I would start with a bit of context once I can figure out how to use technology myself. I thought I'd start with a little bit of context about what Google is doing in health overall, just to better contextualize our work in mental health, because as Dr. Califf mentioned, it is a confusing, large place and often a little bit opaque from the outside. So Google Health is our company-wide effort. The work I'm going to speak to spans all of Google, so I'm not talking about Verily, so not the alphabet lens, but talking about all of our consumer enterprise products, our research in developing novel technology. And what our health team does is we sit at the center of all of it. We have a central health team, which I'm on, which gets embedded in every different part of Google where there's anything health-related going on. Sorry, I guess I need to hold it up. In the words of our CEO, we often talk about making a more helpful Google for everyone. Health is really core to our mission at Google. When we say helpful, we mean giving you tools to increase your knowledge, success, health, and happiness. This goes all the way back to our 2004 founders letter, which talked about the importance of health to Google's mission. And while the shape of that work has had many different stages, it's really a permanent and important part of our company. Our work cuts across three main areas. We call these the 3 C's that really guide the principles behind our health work. We talk about our investment in consumer health, caregivers, and our work in the community context. And so I'm going to largely focus on our consumer and public health work, which is really our community context. Caregivers is where we work with cloud, with partners such as health systems, governments, et cetera, to really help them make the best of technology in the service of their mission. And so there's a lot that we're doing in that context as well, and making the use of AI and diagnostics, but I'll tell you a little bit more about consumers. Because 3 out of 4 people in the US and more than 50% of people in the UK and many other countries turn to the internet first for information about their health. And so as much as my doctor tells me not to Google it, it is the place where people go. And we believe we have a responsibility to make sure that when people turn to the internet first, that they get accurate, credible, understandable, and helpful information. And we see that that is incredibly true when it comes to mental health. When we look at Google search data over the last several years, we see this astronomical increase in the rate of searches specific to finding help for mental health. So specifically search terms like mental health therapist or mental health help, and associated terms have reached highs in recent years, as you would expect given the crisis that we're in mental health. And one of the numbers that just my mind can't quite wrap itself around is the number of annual searches globally on YouTube for mental health is 25 billion. So 25 billion times somebody has gone on YouTube and typed something about mental health into that search bar. So we have this just kind of mind-bending opportunity to help improve the health of billions of people worldwide. It's an incredible responsibility, and it's one that we take very seriously, which is why we have people like me and other clinicians, health equity team, ethicists embedded in our work across the company. And this is an urgent problem that we need to work together to solve. Just to frame this topic for you, 1 billion people in the world today are in need of help for mental health. 1 billion people suffer from a mental health condition, and 5% of deaths worldwide are attributed to alcohol alone. Our youth mental health crisis is staggering. 1 in 6 youth experience a mental health disorder each year. And this disproportionately affects communities of color, as we've heard about already today, who are 1.3 times more likely to experience a mental disorder and are also far less likely to be able to access help. That on top of the statistic that it takes on average about 11 years from the time somebody is diagnosed with a mental disorder or starts experiencing symptoms and actually accessing help. This is the #1 cause of disease burden. These are sobering statistics and reinforce the need for really urgent action, really at a public health level. And so to frame our work in mental health, because we all have some things that comes to mind when we talk about mental health, I like to frame our work with the WHO's definition because it particularly resonates with me. And given that our work is global, we've adopted this internally as our way of thinking about mental health. So just to read it to you, mental health is a state of well-being in which the individual realizes his, her, or their own abilities, can cope with the normal stresses of life, can work productively and fruitfully, and is able to contribute to his, her, or their own community. And when we think about this, I realize that it might be harder to read, but when we bring that into the context of product development, so building digital tools and features, this is what I use internally as a guide for our teams because it uniquely blends a medical model, which is what you see on the x-axis of no disorder to severe disorder, so severity of a condition, as well as that WHO framework of well-being. And so mental health is not linear. Somebody can move across this paradigm in a way that doesn't progress slowly and gradually. We know that from looking at the way that suicide is showing up in youth right now, where somebody can go from being completely fine, have a breakup, and then make an attempt. We see that in adolescent girls in particular right now. So it's really important that we understand that this isn't linear, and we also need to appreciate that many people live with a mental disorder and can still obtain that WHO definition of a fruitful, full, healthy life where they contribute meaningfully. And so this model creates the space for us to understand the role of recovery, which you see up there in the top, as well as this incredible opportunity we have for leaning into prevention, which I'll tell you more about. And I believe we have a role across Google's products to play in every different stage of people's mental health journey, and I'll break this down for you. I realize there's a lot going on in the slide, so I'll walk you through this slowly. But for us, we believe that information is a determinant of health, and we have a unique opportunity, given that we are an information platform, to elevate the quality of health information. But it's not on us to define what quality health information actually is. And so we turned to the National Academy of Medicine, to the WHO, to come up with external principles, publish those, to define authoritative health information. We then took that and internalized it into our product development, and we built a few things that you'll now see in Google products on YouTube and search. On YouTube, you see, if you search for a health topic now, you'll see this little, if you're on your phone, it will be a horizontal video carousel with a title, From Health Sources. And that indicates that all of the content in that corpus of videos, in that collection of videos, come from organizations that meet this NAM and WHO criteria for being an authoritative source. We also have brought that into some of our search features. So search features are these things that you see above organic search results. So there are things that we have made to help organize the information to make it more understandable and accessible for people. Where we've brought this authoritative lens is into our related questions. So you see, if you've ever done a search and you see a little text that say, people also ask, with these expanding answers or questions, those are filled with authoritative sources. So websites that are from public health authorities, advocacy organizations, and others that fall into this initial definition of authoritative sources for information. We also index those first on our web listings, so the first blue link that you see. And then we also, for a number of years, have had a feature that you see on the far right called knowledge panels. And so that's those come from authoritative sources. So in the US, we've worked with the Mayo Clinic to develop many of those. We've worked with the National Alliance for Mental Illness to develop our mental health knowledge panels. And that is where you see credible information about common symptoms, diagnoses, treatments, and where to find help and resources. And we know that authoritative information is incredibly important, but it's also not necessarily the most engaging. And so especially for young people, we find that many of our authoritative health creators, so organizations that are using YouTube as a way to reach populations, partner with celebrities, creators, or youth themselves to co-create content. And so that's what I have on the screen here is our YouTube Kids app, and some of our videos that show up in our supervised experiences product in YouTube, which is basically the YouTube, a parent-controlled experience over YouTube. And we find that when we have that combination of like the Academy of Pediatrics plus youth in the Asking for a Friends series that they did, that content is incredibly engaging and works very well. It addresses that kind of for us, by us, plus the facts from a pediatrician. So that model of content creation works incredibly well for that blend of authoritativeness and accessibility and authenticity that we know is important. Building on that, we have a feature in YouTube called Personal Stories, where we've actually curated videos that highlight lived experience of health conditions. And so if you're searching for depression or cancer, basically what you see on YouTube is now first that health sources, then the next set of videos will be personal stories. And that's been incredibly well received and was a product that we've worked on for many years in partnership with many advocacy organizations and individuals with lived experience. We also have built that into our search results page for suicide queries, where we highlight from authoritative sources. So if SAMHSA or any Mental Health America has lived experience videos talking about recovery and hope related to suicide, those are the videos that we surface to users. So they're finding that inspiration and hope in language that's accessible and people that are like them, but still coming from sources where we know there have been some clinical review to make sure that they're safe and effective. One of the most important needs that we meet through Google searches is helping people understand what they have and put a name to it and know what that next best action is in their health journey. So when that comes to mental health, one of the things that we've built are mental health self-assessments. So we've taken the PHQ-9, the GAD-7, screeners for PTSD and postpartum depression. We've put them onto search. They actually are on a product separate from search. We do not keep that data. It's just used locally on the individual's device to give them the results and the recommendations, but it's not stored in spite of many public health organizations' desire for me to tell them the prevalence of depression. There's certainly a public health need for that kind of immediate surveillance data, but we've indexed on the side of privacy. And so we surface these self-assessments. Currently, they're linked via the knowledge panels on search that I showed you. And those take people to, they give you the result, but they also then link you to appropriate country-specific resources. And we've partnered with NAMI on the copy for that page and on the resources that we show. Next, many people are not yet aware we own Fitbit, so I'll just clarify that at the start. But mental health is also about holistic health, and one of the things that many people forget is that your activity level, what you eat, how you sleep, how you look after your body and mind is incredibly relevant for mental health as well. And so with Fitbit and with our devices portfolio, so that means Fitbit, the Pixel family of products like phones, tablets, and Nest, really think about how do we use that ubiquitous technology in your life to foster the conditions for mental health or empower people with the information and awareness that you need to then change your behaviors. And so Fitbit specifically, we've just recently in the last year launched an EDA, that's an electrodermal activity sensor. So it's basically looking at your sweat and using that as a measure for stress detection so that people are more aware of their stress throughout the day, which also then enables you to better manage stress throughout the day to improve sleep at night, reduce risk for exacerbating conditions. And that's often combined with our mindfulness content that we have in the Fitbit app. One of our most long-standing investments in mental health at Google is our work in suicide prevention and domestic violence support. So we have in multiple countries long-standing feature that is called a one box. It's basically the boxes you see on the YouTube and on the search results page, which highlights a country-specific hotline for suicide, domestic violence. YouTube also has one for eating disorders now. And we work closely with organizations from many countries to surface the right information. But what I want to also explain is how those work, because on our products, that's one of the first places where we actually applied generative AI that Google developed many years ago, but has kind of sat on for a while. And one of our first use cases was suicide prevention and detection that a query, meaning what somebody types into that search menu, is actually a crisis query. And the reason why this is important and why generative AI is an incredibly useful tool in the service of that is language is complicated, and crisis language is particularly complicated. And our models historically were misidentifying long strings of text as information seeking, or they would lose the context. So with our current AI that we use behind this feature, it's called Multitask Unified Model. It's 1,000 times more powerful than the previous AI used on search. It is multimodal and it's generative. So it means it can understand multiple different types of information, audio, images, video, text, speech, and also generate that. But it means it is more accurate at identifying a query. So for example, if the query was Sydney suicide hotspots, you and I would understand that that's likely somebody looking for a place to end their life in Sydney, Australia. However, our models would have previously classified that as information seeking because hotspots is a term used to find kind of popular tourist destinations or places to go. Or a domestic violence query, such as, why does he hurt me when I say I don't love him? They would have just not understood because there's too many words in that sentence. And so MUM, this current AI, is much more accurate. It was a major leap forward in our ability to get it right, which means when we understand that's what's actually going on, we can trigger these features that we have on search and on YouTube to better intervene and support users in that moment. Our work is not only about things that we build on our own products, it's also about how we support the overall ecosystem. So I wanted to share a little bit about what our google.org arm is doing in partnership with organizations like Vibrant Emotional Health, the WHO, the Trevor Project, Reflex AI, to also take our technology and talent and of course our search ad grants and enable and basically bolster the capacity of the ecosystem, because we're only as helpful as the environment is, right? We help identify things that are going on. We help surface information at the right time. But if there's not a place for someone to go or someone for them to talk to, it's not particularly helpful. And so that's a really important focus for our team's effort. And that's why, just to give you a couple examples, we've helped the Trevor Project leverage our AI to better train and scale up their volunteer training for their LGBTQ+ crisis support for youth. We're currently working with Reflex AI to scale up a chat bot to train peer crisis counselors. So the support is still delivered veteran to veteran, but we can help them train more veterans and equip them with the key skills to understand how to effectively respond to someone in crisis through the use of technology. We also have a really important role to play in substance use disorder and recovery. And just to give you a couple of examples of work here, we use our most valuable real estate, which is on that first Google search page. You'll see this little line of blue text that's called a homepage promotion. We use those very sparingly. And every National Drug Take Back Day, National Recovery Month, we supported the first Fentanyl Awareness Day. So we highlight those awareness moments. It's incredible the reach that we have through those. Those bring users to a page that's called Recover Together, which we've made in partnership with many advocacy organizations. And it is essentially a landing page to help people navigate their recovery journey. And a couple of the tools that we've built into that page you see on the side of the screen. We have leveraged our Maps API to map every recovery group that's listed. And so there's a searchable database and Maps tool to help people find recovery support groups. We've also mapped pharmacies where you can obtain naloxone, as well as safe drug disposal locations. And there's a lot more work in that category, but just to give you a few things. The other piece, so I've talked a lot about our product development work, which is a real focus area for us, but policy, our internal policies are another lever that we have. We have policies that govern what can show up in a search feature, what can show up in an ad, what content is allowed to be put on YouTube. And that's an important way for us to shape the overall kind of online ecosystem and draw the line. And I'm going to unpack this with an example in a moment. So one of our most recent launches that we announced in April was around eating disorders. And this is particularly close to my heart. That's my specialty area. And this example shows you the power that we have when we bring together these different levers of policy, of product work, of partnership with advocacy organizations So what we did for eating disorders was we have had a long-standing policy prohibiting content on any of our products that advocates for or promotes disordered eating behaviors. But what we did, we decided that's not enough, and we worked with eating disorder prevention experts and organizations to apply an eating disorder prevention framework to our policy. And so now content that shows imitable behaviors, so for example, this would be content like what I eat in a day, or shows excessive exercise, Hello Kitty diet. There's a number of this is the content that can be prolific on social media platforms that can exacerbate risk for eating disorders. We now remove that content from YouTube. We also remove content that shows weight-based bullying, which is another risk factor for eating disorders. And so we've essentially operationalized eating disorder risk factors and put those into our policy to remove content. One of the things that is challenging about eating disorders is that the recovery videos can be 98% incredibly helpful and inspiring, and then those 2% of that video can describe behaviors that can exacerbate risk. So we, in addition to this remove policy, we have added an age restriction. So 18 and under will not be able to see eating disorder recovery videos on YouTube because so many of them exacerbate risk for eating disorders. And so that was, as does content that is exempted from our policy that is artistic, educational, scientific. And so all of that content is important to have in the overall ecosystem, but we think is not appropriate, and our experts advise us is not appropriate for youth. So that's age restricted. Then one of the other changes was on the watch screen. So if you're watching a YouTube video, that screen is called the watch screen. Right underneath any video related to eating disorders, there is a link to the National Eating Disorders Association helpline. And so we've had that hotline in other places in the YouTube product, but we're bringing it front and center on videos so that you have that moment of inspiration watching content. It's one click to get into that chat or call with a trained counselor. We also worked with the National Eating Disorders Association to make a year-long content series about eating disorders. And that's an area that we need more high-quality content in. So this is an example of how we try to partner with the advocacy community to really use YouTube and the features that we've recently built as a way to get the message out and elevate the quality of information. Next, just a couple more slides. We also feel that we have an incredible responsibility to advance research and understanding of the effects of technology on well-being. And so we've built a research study platform called Google Health Studies, and one of the first studies that we've enabled through that platform is one that examines the impact of social media, of digital technology on well-being. That's with a researcher, Professor Nick Allen, at the Digital Mental Health Center at the University of Oregon. And we plan to do more research on this topic so that we can really understand the nuances of technology, because all technology has benefits and risks. And the more nuanced our understanding is, the better able we will be to build products that are health promoting by default. And this is not to say that we don't already have features built in. We have a number of different digital well-being features enabled and enabled by default for youth across YouTube, our Android devices, and Google Assistant. And then we also have a media literacy program that we run and enable as a curriculum for schools called Be Internet Awesome, which helps youth and their parents, caregivers, teachers improve online literacy and digital safety for kids, which is an important complement to approaching mental health. So that was a lot. I think we'll transition to questions. Thank you.
Thank you so much. That was incredible. As you were talking, I was jotting down questions. I have so many, but we will also be taking questions from the audience as well. I'll ask a few, and then if folks want to start lining up at the mics, that would be great. So you provided some great case studies on areas that Google Health is focusing in the mental health space. How many of your organizations out here now utilize apps? Okay, a few. How many of you use apps? Yeah, okay. How can these lessons that you've learned at Google Health be used by other organizations to increase patient involvement?
Well, it's a great question, and I'll build on some prior speakers' comments about the power of human-centered design, because I'm a clinical psychologist by training. I started my career as an academic building digital prevention programs for youth mental health, and was quickly informed by said youth in a focus group that it looks like someone who thought they understand kids built this. And so, being put in your place at, I think I was 21 at the time, I wasn't that far away, but it quick, I learned the hard way, and luckily early on in my digital mental health career, that you really need to deeply understand the people for whom you're designing and build things in partnership with those communities. And so that is really core to our ethos. It is just, as prior speaker mentioned, just good product design. Is things should be easy, simple, natural. You should see yourself reflected in the technology that you use, in the content that you consume. And so that, whether it's, my academic hard lessons, my time at Headspace, or, our approach to product development at Google, I think the methodology of human-centered design, which, just for those of you not familiar with it, starts with desirability. What do people actually want, and what are their unmet needs? How can you understand that and describe it in their language? Not what you think they need, but what they think they need. And how do they want to engage with that? So that's really going in with curiosity, not I want to build this, or we can build this, how do we put it in? How do we make someone use it? It's really not having preconceived notions about what the end solution or app or digital product looks like. And it has a structured methodology for helping you explore desirability, and then really think about the feasibility and desirability. So what are you good at? What is your organization's strengths? How do you capitalize on that in the service of this need that needs to be met for your target population? And then how do you do that in a way that is actually viable for your organization? And so is there, and this was something that I focused on a lot early in my career, because when when NIMH gave me grants to develop apps, or before apps, online programs for mental health prevention, we had incredible evidence. We showed that they worked. We disseminated them largely. And then the grant would end and they would go away. And I would get an email almost every day from a parent, how do I get my kids access to this? And I had no answer. So that's what propelled me, 16 years ago into technology, was we need to figure out a business model for dissemination of digital mental health technology, because nobody wants to pay for it, and somebody needs to pay for it, and we need to figure out how to make that possible, because many of the people that we're trying to serve can't pay for it themselves. So that's the other piece, is the sustainability of dissemination, and really thinking about, does it make sense for you to build an app? Does it make sense for you to take your strength and put that onto another platform? And so in my work outside of Google with advocacy organizations, that's a big area of focus, is just really understanding your strengths and then thinking about the most effective way of leveraging that in the service of the impact that you want to make. But human-centered design is my favorite approach.
We were having a really great conversation about lived experience before we came up here. At Mental Health America, we saw an uptick in our online screenings during the COVID-19 pandemic. My question is, as more people worked from home or went to school from home, how did Google and YouTube see a change in the ways that people searched during the pandemic?
Well, as I showed you, it just blew through the roof. And so I think one of the things that we've seen, and the data shows this, is that adoption of technology is here to stay for mental health. So while telehealth was, had its peak and then receded for other types of specialties, many people prefer to talk to their therapist over video or prefer a different modality. My early research when I was at Stanford showed that, with college students, showed that young adults and adolescents strongly preferred self-management, support from a peer. They wanted to be empowered with the right tools, but they did not want to walk through. I literally had patients coming through the fire escape to get into my office because they would not walk through the front door of psychiatry. And so there's, I think what we see and what we continue to see is that digital mental health is not a COVID phenomenon. It was, certainly sped up by COVID because it was our only option. But it is meeting a real demand. And that reinforces the need for us to do it well, to make sure that we have really high quality, evidence-based digital tools for people, and make those available widely.
Great. You mentioned several patient groups that you work with. How can other patient advocacy groups be more involved in your work? I know many of the NHC members who are represented here would love to work with you all.
Absolutely. So one of the reasons I was excited to tell you about our features on YouTube is that those are available to any advocacy organization, any individual licensed clinician. And we have an application form because what our criteria is that the organization, whether it's a company, a nonprofit, an individual, has to have a licensed healthcare professional who takes responsibility for the accuracy and quality of the content. They have to commit to a few other kind of quality principles that we have for health content. We verify their licensure with a third party, and then they are eligible to be included in our health features on YouTube, which basically means your content is surface first to users because it's included in those features that I described earlier. So you can go on our YouTube.health site, and there's an application form to fill out. That's a great way to start the YouTube journey. Once people have built up more traction for their channel, organizations are eligible to receive some partnership support from our YouTube Health team as well. And going through that application form is the best way to get started.
Great, thank you. It looks like we have a question from the audience.
Yeah, hi, Leah Howard, National Psoriasis Foundation. Thank you for that talk. That was really interesting. I want to pick up on one of the big questions that Dr. Califf talked about earlier, and that's misinformation. So I'm curious your thoughts. Many of us here in this room probably spend a lot of time talking with our communities about what is and what is not good health information. And I find that whenever there's some celebrity that comes out with something on psoriasis that's not actually science-based, we end up having to write a whole lot of articles about that because that's a term or question that people start Googling, and then they're getting some not good information. So I'm curious as to how you all think about that, and in addition to that, what role you think that the patient community can play with Google on that topic.
It's something we think about a lot. We think a lot about social determinants of health, and we think information is also a determinant of health. And when we work, we come up with internal standards around authoritativeness, but in this is a great example of a place where we said we have the capability of defining that internally. We have many qualified people that work at Google who could do that, but this needs to be an external conversation. This is something we as a society need to have a clear point of view on and derive scientific consensus around. And so that is why we asked the National Academy of Medicine to come up with this authoritative health framework and principles for, at a source level, what does authoritativeness mean? Because the accuracy of any specific piece of content is something that is much harder to ascertain, but we can, come up with very generalizable principles at a source level. And so that's been our focus, is essentially elevating trusted sources, and then the WHO has helped internationalize that framework for us.
Thank you.
So I have a quick question for you. So diabetes is 24/7, it doesn't stop. Has Google tried to kind of mimic this mental health with burnout and disease state management? And the reason why I ask is that having medical devices, they're great, but sometimes we get tired. We get tired of the alarms, we get tired of the, you ate this pizza, so your blood sugar's 400, and you just want to throw the technology away because it's getting on your nerves. So I guess my question is, have you ever thought about you doing something similar with disease state management, especially since there's not a lot of healthcare provider or mental health providers that actually specialize in treatment of diabetes mentally, and also diabulimia and other conditions that come along with diabetes as well?
Yeah, it's a great question, and I think the most I think currently the best tool we have is trying to build supportive communities around these topics through YouTube. Is really, like you spoke about so eloquently earlier, the power of once you find that, once you saw that checkbox that actually was the diabetes 1.5, that is such a pivotal moment for people in their health journey. And so I think for us, that is where we want to create the conditions for those communities to come together, to share information with each other, for those communities to be supportive and safe spaces on the internet. And that's probably the most effective way for us to address that is, but it requires partnership because we're not making that content. We're trying to structure the products in a way that elevate that content and make it visible to the right people at the right time. But we need organizations like many of yours to be the ones that bring that authentic voice into the equation.
Thank you. Great presentation. Another great presentation. So my question comes with, you said something that some of the content trigger or exacerbates risk, right? And then, I work for the National Hemophilia Foundation. My name is Maria Santaella. So part of what we try to do is understanding the association of chronic health and mental health, right? I mean, there's a huge correlation between the two. And so we can't really address it unless we assess it. And so part of it, and you also mentioned the GAT-7 and the PHQ-9, some of those questions are very delicate questions. There's always been a concern that some of those questions might actually create some stress on the person that is answering that. And so I'm also a clinician, I'm a nurse, I worked in a clinic for a long, long time. It's like you never ask those questions unless there's supervision around those things. And so I'm thinking about the content that you're providing, I'm thinking about you presenting people with the, these tools that are used to assess mental health. And then when they're in their pajamas at home, or God knows what they're doing and what they're thinking, right? So what's the liability, what's the responsibility? And maybe through tools like yours, we'll be able to understand that maybe we are not exacerbating risk. Maybe we're actually helping people find the support that they need during those. But I don't think we've ever been able to understand that fully. And so in the absence of understanding, we're just pulling away because we're scared of going there. So I would love to hear what you think, or from your experience, the correlation between the two.
Yeah, I think there are a couple of principles behind that get at your question. One is removing gatekeeping in health. So really thinking about the power of enabling people to understand what they're experiencing themselves. If I don't want to talk to somebody, if I don't feel comfortable using the word depression with my primary care physician, they're not going to screen me. Or, having been given the Edinburgh postpartum assessment as routine OB care with multiple pregnancies, the nurse handed it to me and said, you just have to check this off. And this very dismissive delivery, so which didn't really make me feel like I could be honest on I'm a psychologist, right? So it was, there are pros and cons, is my point, of every different way of doing this. But I think one principle that's really important in screening, and maybe you can speak to this because Mental Health America does incredible work in screening, is that clinically you do need to pair screening with resources. And so that is why we worked with NAMI to help us with the text on the page of the screen, the resources that we recommend after the screen. If you did a screen and had nothing for someone to do, there's research that shows that could be harmful. And so that's why that partnership for us with advocacy organizations. And as we think about bringing that work to multiple countries, there are many countries where I have nothing to show them because there are not resources. And so that means we need to have a dialogue with that country and communities within it about how do we close that gap, because this is something that's helping save lives here. But it is a balance, and I think that's where it is so important to have clinicians in the room, work with researchers, work with the advocacy community to make sure that we are getting these features right, because there could be well-intentioned, let's just take the peach cannon and put it on search. And fortunately, many years of consultation are behind the scenes in terms of our approach to doing that. Anything you want to add?
No, that's exactly right. We, with our screening program, we also list or pair everything with resources after you take a screening. You don't want to give someone results and then say, okay, good luck. There are multiple resources, and then you can also take those results and bring them to someone who is trusted, whether that's a clinician or a friend or someone who can help you do something with those. So exactly right with what we do with our screening as well.
Hi, great presentation again. My name is Regina James. I'm Deputy Medical Director at the American Psychiatric Association. So my question is actually a follow-up of the previous question with the behavioral tools that you have to assess depression, anxiety, and PTSD. So now I've heard that on the page you have resources for people to go to if they happen to, I guess, score a certain number on these tools. Just wanted to know, A, have you followed up on the data in terms of what has happened since you've introduced this tool, and what have been the consequences of this in terms of, people seeking primary care or seeking care with their mental health provider?
Yeah. I think you have a lot of data on that, right?
We do, yes.
So we don't have data on that because we're search. And when we built this, we felt it was really important for people to not worry about what data. We didn't want search to have your mental health data. It's not data that we store. And so how the PHQ-9 and other screeners work on search is it takes you off of the search product onto a third page, on a separate page. Your data is just used to calculate the score, and then it's deleted. So I don't have the longitudinal data, but I think Mental Health America has done really incredible research in that.
Mm-hmm. Yes, we are running short on time, so I will pass it over to our next question.
Great, thanks. Great presentation. Brian Anderson, I'm MITRE's Chief Digital Health Physician. I'm also a primary care physician. My question is about BARD and the generative models and large language models that have been in the news. One of the great promises with digital health technologies is access to care and enabling individuals that might not have easy access to a therapist to get access to one. What do you see as the future for these large language models, these chatbots, in addressing some of the specific mental health needs for individuals in the venue of a chatbot? I mean, I appreciate a lot of the concerns about having appropriate guardrails, not taking a conversation in a particular direction. I'm just curious, your perspective, Google's perspective on the future of chatbots like those for mental health disease. Thank you.
Well, I think they're coming. And I think there's enormous opportunity. One of the things that we're thinking about is what should people build? What should people not build? And then what can we enable so that the right organizations are the one building these? And so, you know, for Google, we're a platform company. We don't typically build kind of specific point solutions for things, or if we do, it's just to show that they can be done and through our research work. But I'd say a lot of the current limitations of these large language models around the compute costs, around hallucinations, those are going to be solved very quickly. And so I would think about what is true 6 months from now, and thinking about the potential. And I think it's really important for us to quickly and collectively come up with principles that we can use to guide the use of this technology with vulnerable populations, mental health being a perfect use case and example of that. But it is, I'd say like there are examples of taking evidence-based interventions, such as one that I worked on many years ago. It's an eating disorders prevention program called Student Bodies, and my former research team has taken that, adapted it. It started as CD-ROM, and dating myself, made it a web-based version, validated it again, made it into an app, validated it again. They've made it into a chatbot, and in partnership with the National Eating Disorders Association, another RCT. And so, you know, part of what I look at is who's behind it. Can we validate it? Can we understand how it works? And there's a lot of potentials. We're really excited about our team's work on MedPalm, which is actually training a generative AI to answer common medical questions, and we've got it to almost the same accuracy as physicians. How that's deployed in real life is a topic for another session.
And I'm sure we could keep going and going and going, but unfortunately our time is up. Thank you so, so much for sharing your work, Dr. Jones-Bell. There will be a 10-minute break, and then we will reconvene at 1:40. 1:40.